Ladies and gentlemen, the next item on the agenda will be a break from our usual proceedings and a most exciting prospect. We will now be conducting a debate on a very intriguing topic, which is bladder preservation for muscle-invasive bladder cancer in 2023. We will have one 6-minute round each in arguing for or against the topic. Arguing for, we have Dr. Manish and Pradhan from Nepal. And arguing against, we have Dr. Jahangir Kabir from Bangladesh. So let me invite Dr. Manish and Pradhan to get us underway. Over to you, sir.
Thank you, respected chairpersons and delegates and faculties present here. I'll be talking about bladder preservation. I'll be talking about four in this case. So, as you all know, radical cystectomy has, along with the neoadjuvant chemotherapy, has stood the test of time and remains the standard of care for treatment of muscle-invasive bladder carcinoma. I'm not here to debate that. However, bladder preservation protocol has been gaining widespread popularity as an alternative, attractive alternative to the radical cystectomy. So why bladder preservation? Because radical cystectomy, as we all know, is associated with significant perioperative morbidity and mortality. It remains one of the most morbid surgeries that we do, and we do lose patients after the procedure. Organ preservation approaches are becoming more common in oncology, like lumpectomy with radiotherapy in breast cancers, limb-sparing surgery with radiotherapy in extremity sarcomas, and now bladder carcinoma, we are dealing with trimodality therapy. The 5-year disease-specific survival rate is quite comparable with radical cystectomy if patients are selected wisely. So what is trimodality therapy? It is the combination of maximum TURBT along with radiosensitizing chemotherapy and radiotherapy. And it should be given, the three of them should be given in sequence, because studies have shown and the guidelines have recommended that any one of them is not superior and is not recommended for as a standalone therapy. So who are the candidates? The patient with significant comorbidities, not fit for radical cystectomy, and also in patient with adequate bladder function and limited burden of disease, but those who are willing and to retain their bladder and they do not want the radical procedures. It is important for the patient to realize that they need extensive follow-up and they should be motivated enough to go through all those procedures afterwards as well. So patient selection ideally would be clinically T2 disease with complete TURBT, no hydronephrosis, no CIS, a unifocal tumor with good bladder function and capacity. All of these need to be there. However, even if it's T3 or T4 disease, inability to perform TURBT, presence of hydronephrosis and presence of extensive CIS along with diffuse multifocal disease is not per se a contraindication. However, absolute contraindication is those with T4B disease with tumor-related hydronephrosis, prior pelvic radiation, and those who cannot undergo chemotherapy, and with prostatic stromal invasions. These are the absolute contraindication. So talking about TURD, its goal is for the maximal resection of the tumor safely. It is associated with a high rate of complete response to the therapy. And even if there is incomplete TURBT, it's not an contraindication for TMT, because studies have shown that a complete response is possible with the following radiochemotherapy. Radiotherapy remains the critical element of TMT. Image-guided, intensity-modulated radiotherapy is now used. It basically can be given in 2 different strategies. Previously, split course was given to see the response earlier and to treat the non-responders earlier with radical cystectomy. However, now a full dose is given to allow for the tumors to shrink and avoid radical cystectomy in those who respond completely. Talking about the chemotherapy, different RCTs have shown that concurrent chemotherapy improves the local and regional control along with the radiotherapy. However, there is no improved in overall survival. So, giving a radiosensitizing chemotherapy like combination of 5-uracil with mitomycins improves the local regional control of the disease. And in those who cannot be given this, gemcitabine and taxanes remains a viable options. There is not much evidence for the neoadjuvant chemotherapy in this setting. Studies done in the past 2 decades have not shown an overall increase in complete response or a decrease in recurrence rate. So it still remains a matter of debate whether to use neoadjuvant chemotherapy in TMT setting. Now, tetramodality protocol have been described from university in Japan. They have selected a very select group of patients where they do all the 3 trimodality that we just discussed, and after that, with the complete responders, they do a consolidated partial cystectomy with pelvic lymph node dissection. What they found was there was still residual tumor in more than 10% with more than T1 tumors, and the lymph node metastasis was seen in 2% of the cases. The overall recurrence rate in these patients was around 4% at 48 months follow-up. 5-year survival was 83% and overall survival was 77%. And they maintained a very good quality of life and preserved bladder function. Renal functions were preserved as well. So they have been advocating for the tetramodality protocol. The role of immunotherapy still remains to be seen. There are many trials currently undergoing using pembrolizumab, nivolumab, and atezolizumab. We'll probably have a result by the end of next year. But whatever information there are from their interim analysis, it's been quite promising. There will be complications associated with TMT, but these are usually well tolerated with grade 1 and grade 2 complications in less than 10% of the cases. And luckily, there are very few grade 3 or grade 4 complications involving the GI and GU tracts. About quality of life with those with TMT, there will be immediate decline because of chemoradiation. However, it will recover at 6 months, and it will remain similar for 5 years. And in case of urinary bowel function and male sexual function, they will be doing much better than the radical cystectomy cases. The surveillance, there's no direct evidence as to how to do the optimal surveillance. Cystoscopy and imaging will be required in 2 years. And for the recurrence, salvage radical cystectomy is done with 10 to 13%, 30% requiring the salvage cystectomy with complication around 70%. And low grade can be treated with TURBT and intravesical therapy. So to conclude, TMT is a viable option, but very underutilized treatment option for MIBC. A teamwork between urology, medical oncology, and radiation oncology is required. Each component of treatment is equally crucial, and good quality of life and overall survival in select group can be maintained. Thank you.